Can you see it now, sir?
We can.
Yes.
Please go right to the top. Go as cranial as we can go. And Shubham, you will have to tell them when you have seen enough and you want them to move on to the next slide. Okay? Right, Shubham?
Yes, sir.
Yeah. So you can tell them after you've seen enough, tell them, but take reasonable time. Don't take too much of it.
Yes, sir. Next slide. Next slide. Next slide. Next slide. Next slide. Yes. So, sir, in the the contrast enhanced CT scan abdomen pelvis, sir, in which we can see. I'm coming to the bladder, sir. So in the bladder, sir, we are heterogenously enhancing irregular broad-based mass, sir, approaching from the posterior wall of the bladder, and sir, it is a sessile mass, sir, extending into the bladder, and there are perivesical infiltration. This infiltration is also infiltrating the seminal vesicle, and
you can ask them to move down to those cuts. Move down to the pelvic cuts. Yeah.
Yes, this one. So the bladder, irregular heterogeneously enhancing mass, sir. This is the perivesical infiltration with perivesical stranding, and these infiltration are also infiltrating the seminal vesicle, and there is a calcification.
Dr. Manish will have a hint for you, I'm sure, Dr. Ganesh also. Before you call it infiltration, look for the fat planes and say the fat planes are obliterated.
Yes.
Okay, there are reasons for obliteration which might not be infiltration. So you describe what you see visually and then sum up with your conclusions.
Yes, sir. So the fat plane between the bladder and the seminal vesicles are simply lost, sir, and also there are perivesical stranding in the posterior wall of bladder, and in the seminal vesicle, the left seminal vesicle seems to be more enlarged as compared to the right. And the fat plane between the bladder and the prostate also seems to be lost. So to sum up, sir, this is bladder tumor mostly infiltrating the seminal vesicle and
prostate. Is there any
prostate.
other finding that you would like to look at again? Have you missed anything?
And sir, sir, in this cut we can't see any lymph node.
No, I mean, you have to look for them. If you look for them, you will see either they're enlarged or not enlarged. Are you missing anything which is obvious? And then we can look for all hidden things. Look at the bottom row images. Hey, stay there, yeah, don't move. Look at the images in the bottom row. Is there something else you shouldn't be missing in uroradiology?
Sir, I think some lymph nodes are enlarged, sir. I can't confirm, sir.
Look again, something very obvious. Manish, maybe you can take over and guide him along. Look at one frame before the last in the bottom row.
Yes, sir. There's a calcification in the seminal vesicle.
Yeah. So is it significant in any way?
Yeah, sir. Could be some.
Could be. Don't see at this stage, even in the exam, you don't have to go to say what it could be. If you know what it is, say it is. If you're not sure about its significance, point out the finding and say we find calcification in the area of the seminal vesicle. Okay?
Yes,
So also in the last film, there is no fat plane between the rectum and the seminal vesicles either. In the last film. So again, while it may not be an infiltration, it is something that needs to be described.
Okay.
And Dr. Ganesh has also pointed it out earlier in many presentations that what you are expected to do in uroradiology is describe the findings. Reserve your impression for right in the end.
Yes.
So now, would you like to give us a stage for the tumor?
Sir, the stage would be, sir, the TNM staging would be, sir, T4A, N1, M0, sir.
What is the origin of the tumor?
So the origin is from bladder, sir.
How do we know?
Because bladder, we can see broad sessile mass which is going
It
downward.
could be something arising from the prostate going into the bladder, because we can't find any difference between the prostate and the bladder base.
It could be, sir, but more likely it would be bladder going into the prostate.
It could be. Okay, hang on. Now, are there any radiological signs you would have liked which are missing in the films that you're seeing?
So in the prostate, we can't see any prostatic growth, sir, as such, which is going into the bladder. We are mostly seeing the bladder growth going towards the seminal vesicle and prostate.
See, the things that you should be able to point out is that this poor post-contrast opacification of the tissues that you are visualizing, and that there is no contrast in the bladder. Okay, these are important radiological findings. If you find contrast enhancement, you say yes, there is contrast enhancement. If you don't find it, you say you don't find it. Why isn't there enough contrast enhancement? Why do you think that's happened?
Sir, in bladder, sir.
Does it look like a contrast-filled urine? Does the bladder look like it's contrast-filled?
Sir, it is contrast-filled, sir, but not full. Full bladder is not filled with contrast.
Shubham, we had discussed this last time. You had said CT IVU, and we had said that you need to see contrast in the ureter, in the bladder, to say that this is a CT IVU.
Yes.
So, if there is no contrast reaching the bladder, either renal function is not there, or there is a blockage. There is neither in this situation. Renal function was normal and there's no hydronephrosis. So this is not a phase of the CT scan where you would look for contrast in the bladder. Last time we had shown you cuts where the iliac arteries were visible.
Yes, sir. Yes.
Okay, so that was the vascular phase in which they had done the CT scan.
So we need more delayed phase to see the contrast.
So if you're sitting in front of the console, you will tell the technician to wait and take more delayed films. A contrast delineated structure will tell you much better about fat planes, about extent, sometimes about origin, and so on. And your diagnosis will improve to that extent.
Yes.
Shubham, suppose this is a post-chemotherapy situation. Neoadjuvant chemotherapy has been given, and this is the picture that we see. Now, if I asked you to stage the tumor, how would the nomenclature be different? Anybody?
So instead of CTNM, it will become ITNM.
It's described as YP. Don't ask me what those initials are, but it is YP T4 and N1, N2, N0 here. So that YP is added to denote that this is a post-chemotherapy situation. Shubham, suppose I do give neoadjuvant chemotherapy, what would be the ideal response that I would like to see?
Sir, after giving neoadjuvant chemotherapy, ideally after 6th week, the tumor should show a response, and we can evaluate the response by doing the repeat CT scan and cystoscopy. And it could be either, sir, decrease in the TNM stage, or there could be no response. So either of the two can be there, sir. And after that, we can accordingly.
The question was, what is the ideal response? So the answer to that is, if a patient develops a YPT0N0 on further imaging, then that patient is going to have the best response to chemotherapy.
Yes.
Okay.
Yes.
So what is your next step here? Now we've got this CT scan. What will you do?
Sir, I will do, so first we will do the metastatic workup in the form of some blood investigation and X-ray chest.
Let's skip all that. Blood investigations, everything has been done. It's been staged. What surgery will you plan next? We discussed this also.
Sir, the next step will be, sir, to do a neoadjuvant chemotherapy, and further to see whether the after that
do we know the histopathology of this tumor? Dr. Mohan just told you that it might be a prostatic tumor.
No, sir, we don't know still.
So we discussed that you will do a TURBT,
yes,
a TUR biopsy, and then
yes,
you will plan your further treatment. So do we have the biopsy report? I believe we just said management.
So we don't have the biopsy report.
Okay. So suppose I tell you this biopsy report comes as a low-grade transitional cell carcinoma. It's a bimanually palpable tumor, T4. You feel it might be fixed to the lateral wall on a rectal exam, and they report a low-grade transitional cell carcinoma.
So, in case of low grade, with non-muscle invasive, sir.
Low grade. Low grade.
No, I'm very happy you asked that question, because for the adequacy of the biopsy, you have to give a muscle specimen separately. So one, you will ask for whether there is muscle invasion or not. And second point I wanted to make it that for muscle invasive, grade has very little role to play. Muscle invasive was always treated as a high grade carcinoma.
Yes.
So if anybody gives you a report saying TCC bladder, the next step is what happened to the muscle report. If the muscle is absent, it is an indication for a redo TURB.
Yes.
Let's take that same question again. It is low grade. Did you do
If it's a low grade,
Did you do a complete resection is the next question you want to ask. Yeah. Did you do a complete? It's a large tumor. Many people will be shy of taking the whole thing out. So they take a little bit, it comes back as low grade. What are you going to do now?
sir, I will plan a re-TURBT, sir, to see the muscle in
We understand that there was no muscle in the specimen. It's unlikely that if you do just a superficial job, you won't get muscle. But let us assume that muscle was not included and you had this biopsy report, low grade. You got the CT scan in front.
Sir, in case it's a low grade and with no muscle element seen, I will again plan a re-TURBT because there is increased probability of
what sort of re-TURBT? What sort of re-TURBT will you plan?
At the previous site of dissection, I will again do dissection, a more deeper dissection to see the muscle invasion or not.
No, you will not be able to see the muscle invasion. You can just guess that there may be invasion when you do a resection. Dr. Manish told you that is bimanually palpable. Can non-invasive tumors be palpable?
Non-muscle invasive, sir. After dissection, again I will do a bimanual palpation.
No. Also, can a non-muscle invasive bladder cancer be bimanually palpable?
Yes, sir, it can be, sir.
Under what circumstances can it be bimanually palpable?
Sir, if it is a large tumor, sir, more than 3 centimeters tumor.
Again,
Don't give a number. Just say large tumor and be done with it.
Large tumor. 3 centimeters also you might not palpate by manually.
Just say large and be done with it. Yes. So now looking at this CT scan, what is the odd thing out in the CT scan? Just such a large tumor sitting there. Last time we discussed this. There's something unusual about this picture. The location of this tumor, etc.
Yes.
If
Would
that
you
finding
believe this biopsy report, or would you say, no, I don't believe this report?
So as per the CT scan picture, sir, we could see the loss of fat plane between the bladder and seminal vesicles and the prostate, sir. But in the report, they have not mentioned any prostatic infiltration, sir. So there is a contradiction to the report and what we see, sir.
What is the other unusual feature of this? What is the other unusual feature of this tumor that you are seeing? If we are saying that there is loss of fat planes in that area and there is something in the muscle, don't you think that by and large in most patients this would have caused left-sided hydronephrosis or something?
Yes, sir.
Yeah. So that's an important factor to remember that, this fellow doesn't have any hydronephrosis. So is it truly invasive? And therefore, you have to make sure that you do a complete resection. You can't, at the second time you go and you can't do a half job. So you'll have to make sure that you leave no stone unturned to ensure that you get probably total clearance or very, very good pieces of histology to make sure that it is not muscle invasive.
You are also saying you will go back to the previously resected area. You might be wiser when you repeat the resection to start from the edge. Quite likely, somebody found the easiest bit of tumor to resect was what was lying on top and removed that. You are interested in the muscle. So go to the edge of the tumor, take the edge of the tumor which has half muscle and half normal looking bladder. And that's where you'll do the resection. And yes, Dr. Ganesh pointed out, remove as much tumor as possible. If possible, remove all of it so that you have a good amount of tissue for histopathology. And at cystoscopy, endoscopically, you have enough of the bladder to look at and make out whether there's infiltration, no infiltration, ureteric orifices, how the prostatic urethra looks, and so on.
So we can take, sir, prostatic urethral biopsy also, sir, to confirm whether there is infiltration.
What is the goal of taking a prostatic urethral biopsy? Can't take it. Technically, there shouldn't be a problem. But what is the goal?
The goal is, sir, on the definitive surgery, sir, whether we are planning a neo bladder.
No. Before we go to planning surgery, at the time of diagnosis, what is the goal of taking a prostatic urethral biopsy? At the time of diagnosis, yes, it matters later too. But let's look at what it signifies during the phase of
the stage, sir. The TNM staging will change, sir. If the prostatic.
The important thing is you want to know whether the prostate is infiltrated by tumor. Again, for this, it's not enough if you do a urethral biopsy. You must resect the prostate deep enough in the area of the tumor to be able to get tissue, which can then be studied, and you'll get the information about whether the prostate is infiltrated or not. Okay?
Yes.
Yeah, so resection of the prostate around the prostatic urethra.
Yes.
And you should also remember, while doing all these things, you should put all the tissue together in one kidney tray, one bottle, and send. If you're doing a prostatic urethra, finish the bladder, clean everything out, go to the prostatic urethra, do the resection, those bits go separately. They're taken separately, they're labeled separately, and in the request form, you will mention that the prostatic urethral resection or the prostatic tissue has been sent separately.
Yes.
So Shubham, you sent the biopsy report to the first year resident. He reported low grade. Then now you sent it back. Now you've got a junior consultant's report saying high grade muscle invasive transitional cell carcinoma. You decide that this is not enough. I will take this report back to the HOD for more details. So what more details will you ask for?
Sir, I will also ask the histology, sir. What is the histology of the tumor?
Transitional cell carcinoma. It is transitional cell carcinoma. So you mean that you will ask for histological variants present or absent? Is that correct?
Yes, sir.
Okay,
yes, sir.
One. Can you name some of the histological variants?
Sir, it could be adenocarcinoma, squamous cell carcinoma.
See, when you say histological variants, it is assumed that you are looking, it is a muscle invasive transition cell carcinoma, urothelial cancer. So you first start naming the variants in urothelial cancer. Then you go to other
histologies of tumor. Here we are looking at histological variants of a urothelial carcinoma. or what would be mostly a transitional cell carcinoma, which has undergone certain changes due to various reasons.
Dr. Prabhu gave you that question, isn't it? Theory question. Some guys have answer. Imran wrote, the other guy also wrote the answers.
Gaurav also wrote.
Yes. So, did you write that, Shubha? Did you write the answer to that?
Yes, sir.
So you should rattle off now.
Sir, it could be signet ring cell, small cell carcinoma, signet ring cell carcinoma. So these
Okay.
are the-
Please go back. No, please go back and read this part. What else in the histopathology do you want? They've just told you TCC. There are no other histological variants noted.
Apart from that, I will also ask for, is there any tumor growth in the bladder neck or the prostate?
How will they know unless you label it and send it, man? You just send some.
Yes, sir. So
You have to label it and
So
send.
I will inquire, sir, whether all the specimen from all the area has been sent or not with full labeling.
No, they're not
And,
sending. It's your responsibility to send. No? So, what containers, what labels will you affix when you send it for histology? The responsibility for doing that is yours.
Yes.
Would lymphovascular invasion need to be reported? Would CIS need to be reported?
Yes, sir. CIS. Yes, sir. Yes.
Yeah. In such a large tumor, maybe all that may not have too much of a relevance, but the complete histopathology report has to be there for you to take a decision and to prognosticate.
Yes.
Now, suppose I am in the best center in the world and I want to provide this patient with personalized medicine. What else what other information would I ask for?
Sir, I will also do the other investigations to see the metastatic.
No. From the pathology.
See, today, pathology has moved beyond simple histology, isn't it? So there are additional techniques they use. There are additional features they use. Sometimes they use a technique which is not histological at all, but something else. So what other things do you want a pathologist to do so that you can make up your mind about how this tumor is, how to manage it? Let us begin with histology-based techniques.
When you use the word personalized care, it means that for that index patient, that individual case, you want to know what is going to be the best treatment possible to provide him the best survival advantage. So we know that it is muscle invasive bladder cancer. We know that there is lymphovascular invasion. We know that there is no CIS, but we want to go beyond all that. In the standard department, the people will probably go ahead and give him some neoadjuvant chemotherapy and take it out. There will be some fellows who won't believe that and want to take it out. That's it. That's not. I think Dr. Manish is asking for something beyond just this. Personalized care means what? He wants to make sure that this fellow lives another 100 years. How is that? What is he looking for?
We can do that psychology, different biomarkers.
See, broadly, we have some tests and some diagnostic methodologies which will help us further define the nature of the tumor, the extent of the tumor, the malignant potential of the tumor, and so on. And then there are some tests which will tell us specifically, in this individual, this is the problem, and therefore, if you adopt this form of treatment or this treatment drug or modality, this person will last longer than he or she would have if you chose the general line of treatment. So what are those personalized techniques which will help us identify patients who will do better or who will do worse with standard treatment?
Shubham, have you heard the term basal, squamous, luminal infiltrative? Have you read these terms anywhere?
Yes, I have read, sir.
What do they mean?
I don't remember, sir, but I have read.
I think you cannot answer. Kamal, will you be able to answer that?
Sir, we will ask the pathologist for molecular study and gene expression of the tissues to subcategorize them into basal and luminal. And accordingly, some basal are chemo resistant and some luminal are target therapy well responsive. So accordingly, we can manage to give personalized care to this patient.
Yeah, you would need to look at this in a little more detail. One is a risk classification. Then which are the genetic abnormalities that will tell you whether this is going to respond to chemo, not respond to chemo, what is the prognosis. So there are two pathways for bladder cancer. You need to know all those details. Okay?
And while we are about it, the 2016 AJCC classification includes Y as an indicator of prior chemotherapy. YC stands for prior clinical or chemo staging, and YP stands for prior chemo followed by pathological staging, and RC and RP for prior radiation and pathological staging or clinical staging during imaging. So that's the significance of the letter Y. Hopefully they'll make it more obvious when they come up with the next edition of staging. So based on this, based on Y, based on R if it is applicable, based on P, based on advanced genetic and molecular studies, we will take an appropriate decision for a given patient. Right? You get that, Shubham?
Yes, sir.
Okay, Shubham. So I am a very trigger-happy surgeon. I decide that I will not give neoadjuvant chemotherapy, fully understanding that there are some survival advantages to neoadjuvant chemotherapy. Now, I ask you to prepare this patient for radical cystectomy with lymphadenectomy. Okay? One approach would be to give chemo, wait for a downstaging with all its advantages, disadvantages. We will not go there due to lack of time. But suppose I tell you that I want to do a radical cystectomy. Please follow the standard protocol. So what is this standard protocol that I would ask you to follow?
Sir, are you wanting to ask preparation of the patient before radical cystectomy?
Pardon me? You want to know the condition of the patient, correct?
Yes, sir.
Very
It was
good.
presented his ECOG 1 and all that.
Yes.
It was in the clinical presentation.
He's already told to prepare him for radical cystectomy. That means he's agreed that yes, this fellow is okay for that operation. All things are go ahead. He wants you to know how you're going to get on with the job, or
He says this afternoon I'm free, I can do it this afternoon.
I'll just go along with him for a minute, sir. So you want to know the condition of the patient.
Yes, sir.
So other than ECOG, would you like to do any other scoring for this patient? ECOG, ASA, we have been doing for forever. Are there any newer scores or any older scores which you would like to do?
Carnoxy score we do, sir.
Karnofsky, ECOG, they tell you the same information. Are there any new indices for these elderly patients, for these complex surgeries? Any new, any old, anything that you know of?
Okay.
You heard of Charlson? It's quite a popular index that is used in a lot of patients, a lot of articles use the Charlson comorbidity index criteria. Of course, there are others, many departments like all these nephrometry scores. Many people have produced some of these scores.
So Shubham, I would agree. Yeah, there are more scores. Go and find out about them. But now I want you to prepare the patient. Good score, not very frail. Charlson's comorbidity index is quite okay. So now you have to prepare this patient. So I tell you, go on the net and look for this particular protocol. Which protocol do you think I'll tell you to look at?
Patient is scheduled for the operation tomorrow morning. When will you admit him?
So we will admit, sir, 2 days before, sir, 2 to 3 days before, sir.
Why? Why?
Sir, because we have to take the do the all investigation further, followed by take the consent and
So done
tell them
everything.
about the.
Everything has been done. Dr. Manish wants you to get going. So when will you admit him? 3 days before, again do all the tests?
Actually, sir, we are planning radical cystectomy, so we are also planning for some diversion process, sir, for the drainage, sir. So that's why we need to put the patient on liquid diet and bowel preparation. So we will admit the patient.
Exactly what you will not do. So you will not give laxatives to the patient. You will not keep on liquid diet. But there are some other things you will do with the diet. Have you heard of the ERAS protocol?
Yes, sir.
What do these letters stand for?
The early recovery. The early recovery protocol, sir, so that
After surgery.
Patient post-op. Yes, sir.
Okay, so
Enhanced
recovery after surgery. So what is changed about the feeding?
So we don't keep the patient NPO more than 4 hours, and we don't give laxative to the patient, and we don't keep the patient. And also, sir, bowel preparation is not done, sir, because it harms the bowel flora also. And sir,
so if you tell the dietitian, what kind of diet will she give? For an athlete who's planning for training for a particular event, the same thing is done for that athlete also. The same thing we do for this patient. What kind of diet do we give? And what is it called? Okay, so your dietitian will do some carbohydrate loading.
okay.
What else is there in this enhanced recovery protocol that you will tell the patient to start from the day you plan your surgery, not even wait for your admission?
But,
His relatives are telling him, please be very careful, just stay in bed, don't go out here and there. Don't exert yourself.
we will ask the patient to keep mobilized, sir. Then there is no need of any bed rest, and keep mobilized. And during sir, intra, we will do the epidural.
So we'll not go to intra-op right now.
Preoperative. All this is leading up to the patient's admission into hospital.
You will encourage him to actively exercise. You will do breathing exercises, give him an incentive spirometer, ask him to start breathing at least 15 days earlier. So all this comes as part of enhanced recovery.
Most of these patients are smokers. Will you ask him to stop smoking?
Actually, we should ask him to stop at least 48 hours before smoking and do the spirometry and chest physiotherapy, sir.
Intraoperative is usually the anesthetist domain. You please read about it, but there are a lot of changes there. In the immediate post-op, what has changed in the ERAS protocol as compared to earlier?
In the immediate post-op, sir, we will ensure to start early feeding. We will not wait for the platters to be passed. We will start early feeding first with the liquid, followed by the solid diet. And we will maintain adequate analgesia so that patients don't have a pain. And post-op also, we will continue the spirometry, chest physiotherapy, and early mobilization. And along with that, we will keep a check on DVT prophylaxis by asking him to wear the
Okay, so I believe the ERAS protocol can be asked as a separate question. So please go read about it. Pre-operative, intraoperative, post-operative. These are all the sections.
So give him an enema the previous night or...
No, sir, they will not give me.
Oh.
Why he'll be comfortable on table, give him an enema, clean out his rectum.
What is the advantage of an enema?
It clears the bowel, sir, and there is no contamination during the surgery.
It's not a bowel wash. It's not a bowel wash. It's just an enema. What's the advantage of it?
Sir, advantage is, sir, with enema, sir, the peristalsis is not hampered, sir. The bowel peristalsis is not hampered. So the early bowel movement can come post-op.
Does it help in dissection in any way?
Yes, sir.
Either having the rectum full or having the rectum empty?
Rectum is not full, sir, so it helps in dissection also.
There are two schools here. Some people will believe that an enema is not necessary. And some people will believe that in a difficult situation, if by chance the rectum gets opened, at least you won't have shit coming into the wound straight away. It will come later, but at least it won't be there at that point, because there is no doubt that if there is contamination due to feces, then whatever data is there on patients who have had rectal injury, there is a poorer outcome than those who have not had that. Of course, whatever you do to close the rectum, again, most people would close the rectum in 2 layers or whatever it is, if it is done whichever way it is. Again, these are individual decisions. You want to be an extra safe surgeon, you might back it up with a colostomy. Because one thing is very clear. If this patient opens up his rectum in the post-operative period and he has fecal peritonitis, he's dead. So while on one side, there will be two groups of, there will be one group of surgeons say, no, I close the rectum, and if they do close the rectum, there is something that they always do. What is it that they do? If they don't
do a diversion, sir, diversion.
No, they don't do a diversion. These fellows don't do a diversion. What is it that we do? If the rectum gets opened and you close it up, there is something additional that you do at the end of the operation. I'm saying at the end of the operation.
Pelvic drain.
The pelvic drains people will put. Even if you don't open the rectum, they put a drain.
Sir, they will put betadine in the rectum to see any leak is there.
No, all that is there. They do something else.
Flatus tube, sir.
Huh?
Flatus tube.
Flatus tube.
Flatus. No, why you want to put that tube? This particular thing has actually shown to be the most important immediate post surgical maneuver. They all do a very thorough anal dilatation. Not just too much. They just split the anus so that there is no pressure inside. Okay? It drains. So anal dilatation is part of the protocol when you close the rectum primarily without any. So there are two schools here. And you can choose to do what you want. If your boss has closed the rectum and he's got away with it, you don't have to follow the boss because ultimately you are your own boss. And you want to be safe. So you close the rectum and put a colostomy if you want to. And as you gain your experience, you will realize that maybe that colostomy was not necessary. And in individual situations, you have to be sure that you get it right. So the important thing is to recognize it. And in many of these situations, one doesn't recognize the hole in the rectum, which leads to disaster. So you have to recognize it, and therefore, while you have a case like this, you must prepare in your mind, okay, this is likely to give trouble. When I'm dissecting that, there is a problem.
Shubham,
Yes, sir.
you have a very competent young anesthetist, very good at his work, but he says, I have never given anesthesia for a cystectomy any time. So please guide me about what measures I should take. What are the conditions you would like for me to maintain while you're performing your cystectomy? You'll tell him 6 to 8 hours or whatever time is your time. He wants to know what all he should look out for or what all he should ensure while he's giving anesthesia.
Sir, you should check the blood loss, sir. And if there is a increased bleeding, arrange for blood transfusion should be started.
See, all that is your job, right?
Yes.
The anesthetist looks at ventilation, the drugs that he gives, the hydration status of the patient, and the post-operative decision to intubate, extubate, when, and so on. And in addition, whether post-operative analgesia through regional techniques is required or not required. So what will you tell him about your requirements for a good surgical outcome? You want all tissues to heal well. You want the patient's bowels to move early. And you want the patient to be on his feet as quickly as feasible. And the anesthetist says, I'm willing to help you. You tell me what you want me to do. I've never given anesthesia for cystectomy before.
How much nitrous should I give? How much fluid should I give? If I give fluid, which fluid? Should I start this patient on inotropes early or late? Should I avoid inotropes? Should I give an epidural?
Epidural should be given, sir, for better pain control. But inotropes always depend on the condition. If patient blood pressure is falling.
Well, clearly, the answer is not so black and white. That's why you are being asked this. All residents, please go and read a little about this because there are a lot of changes which have taken place in the intraoperative anesthetic management. And you might have a situation where you are confident of the surgery, but your anesthetist is not confident of giving anesthesia. It's the first time he or she is doing it. And your own outcomes are going to depend on intraoperative anesthesia management to a great extent.
Okay.
And here also there has been a paradigm shift in what we want the intra-abdominal conditions to be, what we want hemodynamics to be, and so on.
So, Shubham,
Yes.
I've taken out the bladder, the ureters are all tied up, and I'm stepping out for a coffee. I tell you, please go, or please complete the lymphadenectomy. So what would be the extent of lymphadenectomy that you would like to follow?
Sir, ideally, sir, there are 3 levels of lymph node dissection, sir. The standard, extended, and super extended, sir. So in the standard lymph node dissection, sir, we go up to the common iliac bifurcation and cephalad, and the distally up to the Cooper's ligament, laterally the nitrofemoral nerve, and medially the ureter, sir. And in the extended, sir, we go up to the aortic bifurcation, and in the super extended, we go up to the level of inferior mesenteric artery origin, sir. So in the standard lymph node dissection, we remove the hypogastric, external iliac, and obturator lymph nodes, sir. In the extended portion, we also remove the presacral and the common iliac
I'll
lymph
just
nodes.
stop you for a second. In the standard, specifically, you need to go out and go down and remove the lymph node of Cloquet also. That is your distal motion extent, ideally.
Okay, sir.
Okay. So while the extended and super extended had come in with a lot of fanfare, they have not really proven conclusively that the extra morbidity associated with them is of help. Also, in addition to going cranially, you will also remove the presacral nodes in these.
Yes, sir.
Okay.
Yes, sir.
So now you have not given chemotherapy. Your patient has recovered well from surgery. The histopathology is final that there is seminal vesicle invasion. It is DCC. The other margins are all negative. What other report would you need? Which specific structures would you look at in the histopathology report?
Sir, I will look for the first the lymph node status. I will want to know, sir, what is the lymph node status?
They're telling you 3 out of 8 lymph nodes are positive. Or they just say 1 8 of 8 lymph nodes positive. Are you happy with that? Or do you want something more
And
specific?
ideally, more lymph nodes should be removed, sir. Almost 20 to 25 lymph nodes.
If you have done a good job, you will say, no, there are more lymph nodes. Please do more lymph node sampling. Is there any particular lymph node whose involvement is important to you? You will tell, you might label it separately, or you might ask them, look for this specifically. I've sent it labeled, tagged, whatever.
It's an obturator and internal iliac lymph nodes, sir, because these are the sentinel lymph nodes. So I will specifically look for these lymph nodes, they're positive or not, sir. And also while doing lymph node dissection, I can send these lymph nodes for further section, and based on the result, I can proceed further whether to do more lymph node dissection or not.
See, very rarely will you look at frozen section to know whether you have to do more dissection or not.
These days it's not done because the template is already very clear, especially when you have already evaluated the patient with all the imaging techniques. Frozen section was done in the early days when we did not have all these fancy tools with us to ensure whether the nodes are free or not free. See, so sometimes frozen section is used. So Manish is asking you that, looking at this biopsy report, is it complete? Is it incomplete? And since you mentioned frozen section, in some situations, a frozen section is used. In which situation would you like to use a frozen section? And where?
Sir, in case the pre-op CT is not showing any lymph node involvement, then I will do lymph node frozen section of the obturator internal to do further dissection or not, sir. If already the CT is showing...
That is why you have decided on the basis of the imaging whether this is going to be standard, is it going to be extended, or is it going to be super extended. It's already decided, isn't it? If you don't have any lymph nodes and everything is very clear, you just do a standard lymphadenectomy.
So Shubham, don't get confused by the lymph nodes. In the primary specimen, what is there at both ends that will change your surgical plan? where you, in one side, you would do a frozen section. On the other side, nowadays, we really don't do a frozen section. Primary specimen, at the ends of the primary specimen, what do you have?
We have the bladder and the lymph node and lymphatics.
Proximally, what do you have? Distally, what do you have?
Distally, seminal vesicle and prostate, sir, and urethra.
Distally, you have
prostatic urethra. And
you've
proximally,
taken out the prostatic urethra, you have the pelvic urethra there. Would you like to do a
Yes.
frozen section there and take a decision on table? On the other end, you have the ureter, which earlier we used to send very diligently. Now we don't really send on the ureter, but from the urethral end, would you like to send something? I mean, why would you like to send that urethral end for frozen section? That is what sir was asking.
Because we need to decide on the bladder urinary diversion, sir.
there are two situations, Shubham. In one situation, the patient has said, when you spoke about diversion and all that, sir, whatever you think is good, you do that. I am okay with anything. There is another situation where the patient says, sir, all this is very difficult for me to manage. As far as possible, please see that I pass urine normally. In which of these would a frozen section be important to you?
So when the patient is saying, I want to pass urine normally, then I
What is the role of frozen section there?
to see the any prostatic involvement or apical aspect. The bladder, neck, and prostate involvement, sir. Because only after that we can decide whether to go for a neo bladder or a conduit, sir. So if bladder, neck, or prostate,
The bladder, neck, and prostate has already been removed.
You will remove that in any case.
Already removed. And anyway, you have done a cystoscopy and everything else, but you removed it. So you can't look at that now. You've got the membranous urethra sitting there. Isn't it? And if you are planning to do, as Dr. Mohan is asking, if you are planning to do a neobladder, you want to be sure that the end where you're going to connect the bowel to that urethra does not have obvious tumor.
yes.
All right.
Yes.
If there is tumor there, you will abandon doing a neobladder. You may probably want to do a completion urethrectomy if there is tumor sitting there, which means you have missed that at the initial evaluation.
Yes.
Okay, so these are very important things when you do a cystoscopy. As Dr. Manish said, nowadays we have stopped sending the ureters for frozen section. But there are certain situations where you would like to send the frozen section. In which situation would that be?
So in case when we are doing the cystoscopy and the mass is very close to the...
No. Forget the cystoscopy. We are at the operating table now. We are in the operating room. We have done the cystectomy.
If the tumor is very near to the urethral orifice or then we have a suspicion that whether the tumor is infiltrated into the ureter. So we will always send the distal ureteric stump for the frozen section. Till the ureteric involvement.
No, not the distal ureteric stump. Not the distal. See, there are two situations here. One is where if the ureter is involved by a tumor, contiguous spread from the bladder, or primarily they could be tumors in the ureter, and you have a situation where the kidney on that side is non-functioning. So you go ahead and take the kidney out. Nevertheless, there are certain situations where the kidney is functioning and you want to preserve that kidney. And the index ureter on that side has got tumor below. You're not sure whether you're going to, when you do your Wallace or Bricker, that the ends of the ureter that are going to be there have got tumor. So in those situations, you would probably have to do a frozen section to make sure that the proximal end of the ureter, what is already gone is gone. But what you see with the naked eye, if it looks apparently normal, you want to confirm that and you send that for frozen and ensure that when you're doing that anastomosis, you don't have tumor there. Because one of the dangers of urothelial cancer is the fact that it has got a lot of spread along the lines, especially in the ureter. And a lot of postmortem studies have been done where they've actually looked at these ureters and they found sheets of CIS across the ureter, even when there is an obvious TCC sitting somewhere else. Okay? So ureter is not to be taken lightly in these situations. You understand?
Yes, sir.
Yeah.
I think we're coming to the end of our time, but before we end, we wish to record our profound grief at the passing away of Brigadier Rautre,
Yes.
one of the senior most living urologists, who retired from the army with a very distinguished career and building up the urology services of the army, and later also serving as president of the Urological Society of India. He has mentored several urologists across the country, and for a very long time, he was the returning officer for every USI election because he was a person of great integrity, whose integrity could neither be violated nor questioned under any circumstances. A good friend to so many of us, a mentor to so many of us, and we wish his family finds strength to overcome this loss. His son is also a surgical oncologist, though not a urologist, and was in the Air Force. We pray for the departed soul, and let's hope some of us can set examples as tall as Dr. Rautre set for everybody.
Thank you.
Yes, sir.
Thank you, sir.
Thank you. We'll catch up next week, and maybe when we have a similar case sometime in the future, we can go into the options for use of bowel and other structures in urinary diversion, malignant urinary diversion. Thank you all. Catch up next week. Thanks, Manish.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.